Hey, med-surg students, in this video presentation, I'm going to go over the neurological system. I'm going to start with the anatomy and physiology. I promise this will be brief. And then I'm going to go into the assessment and the important assessment that you need to know for your exams and to take really good care of neurological patients. As you know, the nervous system is broken into two categories: the central nervous system, which is further divided into the brain and the spinal cord. So you'll be learning about brain and spinal cord conditions for this first exam. And the peripheral nervous system, which is further divided into the autonomic system, which means automatic, like you have no control over this, the body just does it. So that's further divided into sympathetic and parasympathetic. And I'll talk about the key features in a little bit in the somatic nervous system. We're going to start with the brain, the central nervous system. The brain has three structures that you probably remember from A&P. So the three structures are the cerebrum, cerebellum, and brainstem. So the brain is responsible for sending, receiving, processing information related to all sorts of things like our sensation, movement, communication, memory, emotions, and thought processing. So it's like the executive center of the body, okay? And we're going to go into each structure in a little more detail. All right, the cerebrum, which helps with our cognitive functions, right, has four lobes. The frontal lobe is responsible for cognitive processes like language and motor function. Temporal lobe is understanding, so processing when somebody's talking to you, and also sensory information processing. The parietal lobe interprets our sensory information, and the occipital lobe interprets our visual information. There are two areas of the brain that you really need to know for your exams and also the proctor. So there's an area called Broca's area and Wernicke's area. And these occur in two different locations in the brain, but they are involved with language and speech. So Broca's area is on the left side of the brain in the frontal lobe, and it is involved with motor of our speech. So how we articulate, how we make words, okay? So if somebody has damage to this area, they're not going to be able to talk, and this is called expressive aphasia. And it is very frustrating to patients when they have a left-sided brain attack and they can no longer speak, okay? They get high anxiety. Wernicke's area is located in the temporal lobe on the left side of the brain, and it is involved with how we process language, how we understand language in spoken and written form. So they are fluent. People who have damage to Wernicke's area, like they can talk, they just don't make any sense, okay? And so that is known as receptive aphasia because they can't take in what you're saying. So the next structure is the cerebellum, and it is an infratentorial structure, which means that it's under the tentorium. The tentorium is a thick membrane that separates the cerebrum from the cerebellum. And the cerebellum helps us with equilibrium, like it helps us balance, it helps with posture, it helps with coordination and fine muscle control. The brainstem is the next structure, and this includes the midbrain, the pons, and the medulla oblongata. So we usually just shorten that to medulla. So the midbrain transmits information. The word pons means a bridge. So pons is the bridge that connects the midbrain and the medulla. The medulla is responsible for all our autonomic functions, such as breathing. Okay, so that's why when somebody has damage to the medulla, we worry about respiratory status. The cranial nerves, 3 and 4, emerge from the brainstem, and the brainstem controls them. So the brainstem regulates our heart rate, swallowing, blood pressure, sneezing, vomiting. Okay, so that's important to know. So one thing to remember about the brain runs on sugar and oxygen. If your patient has a low sugar or they have hypoxia, they can have symptoms that mimic a stroke. That's why anytime somebody has like a change in their LOC, you always check the O2 sat, and the sugar, because those are easy fixes. If you can fix that, maybe those symptoms will abate. Okay, so the brain needs constant blood flow because it needs oxygen to survive. The brain cannot survive without oxygen for 4 to 6 minutes, and the term for that is anoxia. Anoxia. Okay, now our body is amazing the way it's set up. So the anterior brain is supplied by the right and left carotid arteries. The posterior brain is supplied by the vertebral arteries, right and left. And then in the middle is the circle of Willis. So if there's a narrowing and blockage in one area, the circle of Willis will help maintain blood flow. And then the venous blood exits through the jugular veins, and the brain auto-regulates the blood flow in the brain. It's amazing. The brain has protection, right? We have a thick, rigid skull, which provides protection for the brain. We have the meninges that are, membranes that encase the brain in the skull, inside the skull. And the epidural space is the potential space between the skull and the dura mater, and there's arteries in there. So that's why if somebody gets hit like with a TBI, they can get an epidural hematoma. The subdural space is the potential space between the dura mater and the arachnoid mater. And so the subarachnoid space is also where the CSF is housed in the blood vessels. So this is a picture showing like the functions of each lobe and the structures of the brain. You might want to read through this. I can tell you what it will help you with. Like, for example, if your patient has a stroke in the frontal lobe, they're probably going to have personality changes. Okay, or they have a TBI in that area. So knowing what part of the brain does what helps you when the brain is injured in that area to know what to expect. Intracranial pressure is something that we will be talking about a great deal for these lectures, okay? The normal intracranial pressure is 10 to 15 millimeters of mercury. So it's very important you know how to prevent increased intracranial pressure, which we'll talk about later. But it comprises a couple of factors, okay? So the volume of brain tissue, cerebral spinal fluid, and cerebral blood flow. So if there's swelling of the brain, increase in CSF for whatever reason, I'll explain that later, or an increase in blood flow, or a decrease in the venous drainage, this will increase intracranial pressure. The spinal cord is inside our vertebral column, so our vertebral column protects the spinal cord. It sends messages and sensory information between the brain and the body. So what happens is, so in the left side of the brain, the nerves on the left side of the brain are going to cross over in the medulla to the other side of the body. That's why if you have a traumatic brain injury or a stroke in the right side of the brain, you're going to see left-sided weakness. Okay? It's also a reflex center. Knowing the levels can help you if somebody has a spinal cord injury, like C 1 through 3, that and 3, 4, 5 innervate the diaphragm. So 3, 4, 5 keep me alive. Patients that have injury in this area are going to have to be mechanically ventilated for the rest of their lives. The autonomic nervous system, you probably learned about the parasympathetic and the sympathetic nervous system. So the parasympathetic nervous system is also called the rest and digest, or sometimes the feed and breed. Okay, so it decreases heart rate, blood pressure, respiratory rate when we're in non-stressful states. It can also restart peristalsis after we've been, stimulated with the sympathetic nervous system. Okay, the sympathetic nervous system is in charge of fight or flight. So when it's stimulated, we're ready to fight, right? So we can have an increased heart rate, blood pressure, our GI system shuts down, we start producing more glucose to give us energy for that fight, and it also causes dilated pupils so you can see better. and it relaxes the bladder. The cranial nerves are part of the peripheral nervous system, which always really confused me because I would think cranial means CNS, but no, it's peripheral nervous system. They're on the undersurface of the brain. There are 12 paired cranial nerves, so one for each side, right, with the same number. They are described in Roman numerals, so you have to know the Roman numerals, and also by their function, what they actually do. So, for example, Roman numeral 1 is olfactory, and that olfactory means smell. It's in charge with our sense of smell. Okay? Now, doing a bedside cranial nerve assessment, you're not going to assess a real deep cranial nerve assessment. Okay? So, I'm going to give you some tips on how to do a bedside. So, the optic nerve is our visual acuity, but also helps with the pupils' reaction to light. Third cranial nerve is called the oculomotor. So it helps with pupil dilation, or I should say reaction to light. It helps elevate the eyelid. So if somebody has ptosis, they may have injury to the oculomotor motor. And if that ptosis is lagging of the eyelid, and that is normal in aging people if it's both eyes. You just see it in both eyes. If it's in one eye, it could mean a problem. It also helps move the eye, okay, as does the trochlear, which is number 5. Trochlear means pulley, so that pulls down and in. You don't need to know the direction the cranial nerves move the eyes, but you do need to know that 3, 4, and 6 make my eyes do tricks, okay, because they move the eyes. Cranial nerve 5 is sensory and motor, so it's touched the forehead, cheeks, and the mandible, and it also is in charge with chewing. The facial nerve, cranial nerve 7, is a nerve that makes us smile. So you always want to check if somebody has a symmetrical smile when you're doing a neuro assessment. 8 is for balance and hearing. 9 is for taste, but that's not the most important thing about 9. 9 and 10 are in charge of the gag reflex. So those are important, like after, somebody has like an endoscopy, you have to check the gag reflex. Somebody has a stroke, you have to check the gag reflex. Okay? And then number 12 is hypoglossal, and that's in charge of tongue movement. So you can have the patient stick their tongue in their cheek and you try to push on it to see how strong their tongue is. The spinal accessory move is a shoulder shrug. Okay, that's in charge of the shoulder muscles. Okay, health promotion and maintenance. How do we protect our brain and spinal cord? You need to wear helmets if you're out on a bike, a skateboard, whatever, on a horse. You need to always wear helmets, okay? If you work in a construction site, wear your hard hat. Don't dive into water of unknown depth. That can cause spinal cord injury. Use seat belts. Use car seats. If you are putting pesticides on plants or in the house or whatever, wear long pants, long sleeves, and a mask. High usage of pesticides has been linked to Parkinson's disease. Control hypertension. Maybe don't do cocaine and methamphetamine because these can increase your blood pressure and cause a stroke. Now, assessment of somebody with a brain or spinal cord injury is going to include vital signs, obviously. Increased temperature could mean damage to the brain or it could mean an infection. The temperature control center is in the brain, so that's why people with brain and spinal cord injuries might have an increased temperature. So if they could also get a widened pulse pressure, and you have to watch this closely. For example, a pulse pressure is subtracting the systolic from the diastolic. So a blood pressure of 126 over 78 is going to give you 48 pulse pressure, whereas a blood pressure of 136 over 64 is going to give you a pulse pressure of 72. So that's an example of widened blood pressure. The thing is, both of these blood pressures are not going to probably ruffle your feathers. So you have to trend them and watch, because a widened pulse pressure, really wide, is a symptom of increased intracranial pressure, but it's a really late symptom, and the patient's probably not coming back from it. Okay? Look for changes in respiratory pattern. That's another late symptom of increased respiratory pattern. Bradycardia, it happens with neurogenic shock. It happens with increased intracranial pressure as a late symptom. And Cushing's triad is widened pulse pressure, so an increased systolic blood pressure, bradycardia, and a change in respiratory pattern, bradycypnea, so the respiratory rate decreases. We also need to check the LOC and assess their mental function. So a change in the LOC, whether it's they become belligerent, they're apprehensive, they're apathetic, they become lethargic, is the first sign of increased intracranial pressure. So you have to pay attention to those subtle signs. The Glasgow Coma Scale is an assessment tool that we use for patients with neurological function, and I'm going to talk about that on another slide. The Glasgow Total Scale is 15. If it's less than 8, it's time to intubate because they have a severe head injury. A Glasgow Coma Scale of 3 or less means they're comatose. And a decrease of 2 or more points in the Glasgow Coma Scale you need to report. Now you're going to need to know the Glasgow Coma Scale, and I know you learned it in fundamentals, but we have to review it. So there are 3 categories in the Glasgow Coma Scale. They are eye-opening, verbal response, and motor response. The minimum score in each category is 1. The maximum score is either 4 for eye-opening, 5 for verbal response, and 6 for motor response. So that means the lowest score they can get is a 3, and the maximum score they can get is a 15. To remember the maximum score in each area, I have a couple of tricks. You can say, my extra value meal costs $4.56. Or you can remember that if you put on a pair of glasses for eye opening, you called 4 eyes. I know that's not very nice, but it's a good way to remember. For verbal response, I remember 5 is the maximum because in the word 5, there's a V for verbal. Okay. Now I also have a couple mnemonics. So for eye opening, I use ESPN. So if the eyes open when you walk in the room, that's spontaneous, give them a 4. If they open their eyes to stimuli, you give them a 3. So I walk in the room, I say, Mrs. Jones. They open their eyes to Mrs. Jones. Okay, if I elicit pain on the patient by, pressing on their thumb or something like that, I give them 2 points if they open their eye for that. If they have no response, I give them 1 point. Okay, with the verbal response, okay, I use Our Country Win. So if they're oriented, I give them 5 points. If they're confused, I give them 4 points. So confused, and pay attention because sometimes patients aren't going to know the day of the week or the date if they've been in the hospital for a while. So you might have to give them a pass on that one. Words inappropriate, so that's like a 1-word response. Like I say hello and you say moo. Okay, that's inappropriate. Incomprehensible sounds. I say hello, you say okay, that's an example of that. No response gets 1 point. For motor response, you can remember can't live without fan. Okay, you can remember C stands for they obey commands. L is localized pain. You give them 5 points. So you apply noxious stimuli and they try to swipe your hand away. Okay, if they withdraw to pain, that's 4 points. Like say you elicit pain and they try to withdraw from it, that's 4 points. Flexion is abnormal posturing. It's called decorticate. I'm going to go into more detail with that. that's 3 points. An abnormal extension is decerebrate, and that's 2 points. And no points is, no response, sorry, is 1 point. Okay? Now you have to know the ranges and what they indicate. So the Glasgow Coma Scale of 3 to 15 means they have a mild TBA, and the other TBI, which is traumatic brain injury, and the other name for that is concussion. 9 to 12 means a moderate traumatic brain injury, and 3 to 8 means severe TBI. It can be used for other things besides traumatic brain injury. It could be used as part of your normal neuro assessment. But just spend some time learning the Glasgow Coma Scale. Okay, this is posturing, and this is a very late sign to increase intracranial pressure. So the first type of posturing is called decorticate posturing. And how I remember this is flexion is if you look at where the arms are flexed on the chest, I think they're protecting their cord. So their arms are across the chest. That's just the way I remember it, okay? So this indicates damage to the cerebral cortex. And then the next posturing position is decerebrate posturing. And that is described as extension, and that indicates damage to the brainstem. So that's a little more dire than damage to the cerebral cortex, because remember, the brainstem does all our automatic things like breathing. So that's why that's important to know. Another thing and part of your assessment, and you can do a lot of this when you're just watching the patient in the room. So you want to know if they're alert and oriented times 3 or 4. You want to know if they follow commands. You want to know if they're making good choices. You watch them perform their ADLs. Is their gait steady? Are their facial features symmetrical? Are they listening to what I say? So just remember, you can do some of this assessment without doing a formal assessment. Pupil reaction to light and assessing the external ocular movements is an important part of any neuro assessment. So you check the pupil reaction to light, and it should be reactive to light, and you check it directly and consensually. So direct means you check the eye that you're actually shining the light in, and consensual means you check the opposite eye, because it should move and they should be in sync. The normal size is 2 millimeters, so you want to note the size of the pupils. External ocular movements, that assessment tests cranial nerves 3, 4, and 6 that make my eyes do tricks. When you're doing the extraocular movement assessment, you look for nystagmus. Nystagmus is only normal on the lateral gaze. All right, and I'm going to explain what nystagmus is in another slide. And I'm also going to explain how to do the external ocular movements in another slide. But please ask your instructors in clinical to show you how to do this. Nystagmus refers to involuntary eye movements. And you may see this when you're testing the extraocular movements of the eye. It's only normal on extreme lateral gaze. But it could indicate, if you see nystagmus, that your patient has multiple sclerosis, they're on phenytonin, they have a brain lesion, and remember, if they have nystagmus, it's going to be a safety issue. When you're doing an assessment on the extraocular movements of the eye, you guide the eye in the 6 cardinal fields of gaze, and you're looking for conjugate movement. In other words, both eyes move in sync. If they deviate in any way, you note the direction. To check the neuromuscular system, you're going to ask them to follow your verbal commands. Ask them to push against the palm of your hands with their feet to test their strength. You can have them extend the arms and press down on each arm one at a time. And you can look for pronator drift, and you would do this after you thought somebody had a stroke as well. And I call this holding the pizza. You ask them to put their arms out, and then you note if the weak arm will drift down and turn in. So that's the pronator drift. The Romberg test is a test of balance and equilibrium, and you would do this on Patients that maybe complain of dizziness, an unsteady gait, or they have damage to their eighth cranial nerve and you want to test their balance and equilibrium. So you ask the patient to stand with their feet together and their arms out to the side. You test first with the eyes open and then with the eyes closed. If the patient sways while doing the Romberg test, that's called a positive Romberg test. So this is positive usually in inner ear and cerebellum conditions. Okay, a lumbar puncture is highly tested. It's a spinal tap. So obviously it's invasive, so you need an informed consent. You're going to put the patient in a cannibal position, so fetal position, but tight. Okay? It's not done if the patient is suspected of having increased intracranial pressure. Typically, it's done to diagnose what type of meningitis somebody has or to diagnose meningitis. Another nursing implication is they have to lie flat for several hours after. And the reason is if they don't, they're going to get a spinal headache. And spinal headaches are very hard to treat. They have to do like a whole blood patch thing, which I'm not even going to go into because you probably won't be tested on that. Okay. They put the needle in between L3, L4, and the reason is the spinal cord has ended then, and they're going in to get the cerebral spinal fluid. Push fluids after the procedure so that they can replenish the fluids that were lost. If they're going to send the cerebral spinal fluid for analysis. So a high white blood count and protein could indicate the patient has meningitis. If it's decreased glucose in the cerebral spinal fluid, that means bacterial meningitis because bacteria love to eat the glucose. The glucose level in your brain is about 60% of your blood glucose. So it's normal to have glucose in the cerebral spinal fluid, but it's going to be decreased if they have bacterial meningitis. And it'll also be cloudy, whereas viral meningitis presents with clear cerebral spinal fluid. Cerebral angiography. This is a test to see what the vascular structures, the arterial structures in the brain look like, because patients can sometimes have these things called arterial venous malformations or aneurysms in the brain, which means that they're going to be more prone to brain bleeds. Okay? Now, angiography in general uses contrast dye. So you're going to ask about shellfish allergies. You need to make sure they don't have any kidney problems because contrast dye is damaging to kidneys. So you're going to hold metformin, which I don't think you've had before. It's a diabetic medication, an oral diabetic medication, for 24 hours before and 48 hours after, because mixing metformin with contrast dye can result in lactic acidosis, and we don't want to do that to our patients, right? So check the BUN and creatinine and let the provider know if they are elevated. Keep them NPO for 8 to 12 hours. Check on if they have any if they take anticoagulants, if they take antiplatelets like aspirin or clopidogrel, or if they use herbal supplements. And I have all the herbal supplements that cause bleeding in the alterations in neurological function lecture, because that's highly tested on ATI. Okay. After, it's just like a cardiac cath, okay? They either go through the neck or the groin. So you're going to check the 6 P's in either the upper or lower extremities every time you take vital signs. Now remember the vital sign sequence. It's Q 15 minutes times 4, Q 30 minutes times 2, and then Q 1 hour. And depending, usually times 4, but depending on how sick the patient is, it may be more frequently than that. All right, the EEC, electroencephalopography. So this is done usually to determine if a patient has seizures or to elicit seizures, put it that way, to see what the brain's doing during a seizure. Or it could also be done on patients that are thought to be brain dead to see if there's any stimulation on the exam. So it detects electrical activity. Um, the nursing implications is the patient's hair needs to be washed the night before. They could be asked to stay awake before the test because patients that have seizures, um, insomnia is one of the risk factors of having a seizure. They cannot use any sedatives or stimulants 24 to 48 hours before the test. They may be exposed to flashing lights during the test because flashing lights can evoke seizures, and they may also be asked to hyperventilate. Remember when you learned about ABGs, hyperventilation leads to respiratory alkalosis, which can also cause um, seizures. So those are the important nursing implications you need to know. These are terms that will help you with the neurological system that students often get mixed up. Ipsilateral means the same side. So I'll give you an example. If somebody has a left-sided TBI, their pupil may be dilated on the ipsilateral side, which means the left side, so the same side. Contralateral means opposite. So if I have a left-sided brain attack or a left-sided stroke in my brain, that means my right side of the body is going to have either hemiplegia, which is half the body is paralyzed, or hemiparesis, half the body is weak on the contralateral side. And some sources use these two terms interchangeably, just FYI. Dysphagia means trouble swallowing. Dysphagia means trouble speaking. Nystagmus is involuntary eye movement, so I talked about that in this lecture. Know the difference between flexor and extensor posturing, in that it's also a late sign of increase intracranial pressure. Tetraplegia or is the same as quadriplegia. It's the new name we're using. And quadriplegia means 4 limbs, okay, are paralyzed. So those are important terms that will help you. Okay, please listen to the videos before class. Super important to do. Write down all your questions for me. I'd be happy to answer them, and I'm sure if you have a question, your classmates have a question. Let's get it knocked out at the beginning of class so we can clear up those muddy thinking, and it'll help you on your exams.